Hi, I'm Peter Hunt. I'll be discussing the content and research of teaching pediatric communication skills to medical students. This was published 16 January 2015 in Advances in Medical Education and Practice. The reading relates to healthcare communication and a description and review of training provided to medical students in pediatric communication between provider, patient, and parents, as well as on the feedback and the training provided by those students. First, I'd like to briefly summarize the training and the research associated with it. I'll divide the article into two elements: the description of the communication training program and the university's study of the effectiveness of that training. The authors of the article and the associated communications training teach at Cardiff Medical School in the United Kingdom. They recognize the need for enhanced patient-centered comms as a basic skill that all medical students should possess before moving on to training in a specialty. In this training, 2 tutors, 1 general practitioner, and 1 pediatrician teach groups of 10. The students review and discuss a real-world video consultation involving an 8-year-old girl with chronic headaches and her mother, then perform 3 30-minute scenarios with actors, including pauses and tutor-led discussion interspersed within. These scenarios range from dealing with the mother of a 7-month-old child, in this case represented by a doll, to dealing with a 16-year-old male patient and the potentially abusive boyfriend of that patient's mother. Participants, in this case the students, submit course feedback forms for research, analysis, and course improvement. No patient feedback outside of scenario actors is analyzed. Free-form feedback is categorized and scored thematically, while specific questions also exist to be answered. Feedback received from students is generally positive. Following that brief summary of the training and the associated research, I'd like to discuss some of my limitations I found in both. The training is limited, considering the challenges of what I call multifaceted pediatric communication, wherein both patients and parents have input. I believe that for such a complex subject, more time should be allotted beyond the 3 30-minute sessions. As the article mentions, actor-based training also has its limitations, although for the reason of practicality, I believe it's the best possible solution for any large-scale program. In expanding the training resources involved, the training could also be broadened to include communication with geriatric patients and their family members. Both pediatric and geriatric patients have the potential to share the same communication challenges, with family members, guardians, or caretakers potentially making the medical decisions in place of the patient. The students being trained are not pediatricians, but rather are awaiting their pediatric rotation in medical school. As such, there is perhaps a de-emphasis on the challenges of getting clinical information out of a medically illiterate patient and their parent. Most importantly, feedback for the course itself, while well categorized and analyzed, is based solely on the provider perspective. Because it is based solely on the opinions of the student on their own performance, this feedback effectively measures student satisfaction while doing nothing to address patient perceptions of enhanced treatment and communication outcomes. For any healthcare organization rightfully seeking to include patient-centric communications, it's key to actually communicate with those patients and seeking feedback, though some filtering should occur to address differences in healthcare literacy between the patient and provider. With the summary and critique out of the way, I'd like to leave the audience with a handful of discussion questions. Number 1, what similarities and differences do you see between pediatric and geriatric communications, and how can these be efficiently addressed in a training environment? 2, what challenges do you foresee for a provider in diagnosing and treating children with non-compliant parents, for example, in cases of child abuse? 3, do you have suggestions, broad or specific, for improving training for providers in multifaceted healthcare communications, i.e. between provider, patient, and parents? 4, how much value should be placed on patient feedback of physician training and performance? Does this change depending on the patient? For example, a minor versus an adult versus a senior. To conclude, I found the training and the resulting study to be a reassuring sign that healthcare education organizations at least recognize the need for communication training, especially in the challenging specialty of pediatrics. I believe that a major part of patient-centered communication, though, should be reception of feedback from those patients. In this case, feedback from actors and tutors should fill that role and should be more important than the student feedback in improving the training.